Greetings, everyone. Yes, we are here with another session. So, a successful histopathology is about it's just about knowing when you are having a, sorry, okay, when you are looking at a typical picture, which normally gets all the oohs and ahs from everyone looking at it, and when it may be something else hidden behind that typical picture. And as you might imagine, these two wonderful pictures that are there, histopathology pictures, have a hidden story. One of them is exactly what it looks like, but one has something else behind it. To know what it is exactly, well, you'll need to hang on with us till the end of the session. Now, today we have with us Dr. Punnya to take us through a medley of cases for exactly the same reason, where we find out which and when we are looking at something typical and when we are looking at something atypical. And this is the most proven and the tested way of learning histopathology, of course, which all of us know. Yes, like I said, for this, you will have to wait till the end of the session. And sorry. Right. And I forgot to introduce myself as usually. Well, this is Dr. Mandana Donahue. For those who are here for the first time, I'm from Oral Pathology 360. We are the channel that helps you to connect with everything and everyone within the range of oral and maxillofacial disease diagnosis and management. So if you like what we do, please hit the subscribe button and please stay with us as we go on with our lecture. So today we have the lecture, which is from Dr. Punnya Angadi, a medley of cases, histopathologic potpourri. And, oops, sorry, I seem to be all thumbs today. Okay. Right. So Dr. Punnya Angadi is the professor and head, Department of Oral Pathology and Microbiology, KLEVK Institute of Dental Sciences and Hospital, Belgaum, India. Now, the whole point, I think, or rather one little side note I can put, is that this very morning I got a message from Dr. Hazare, who all of us know, and he was full of praises for her because apparently he was one of her examiners and she did extremely well. He was very happy that she is on the channel today. And well, that was many years ago. And today, as the professor and head, and with more number of years of experience under her belt, I am sure she has a treat for us. So let's just start with that. Yes.
Good morning, ma'am.
Thank you for joining us.
Good morning. Good morning. Thank you so much for this opportunity.
You are most welcome.
Yes, that's really nice to hear about Dr. Hazare sir. Thank you so much for that too.
Most welcome. Got that message just as I was sharing this morning.
Thank you so much.
Okay, let's start with the lecture. Let me just do this.
Good morning, one and all. Greetings from KLEVK Institute of Dental Sciences, KLE Academy of Higher Education and Research, Belgavi. First of all, I would like to thank Dr. Mandana for having me here today. I have been following the channel regularly and would like to place on record the appreciation of the work being done by Oral Pathology 360 and by Dr. Mandana in particular. I'm sure she is a one-man army running the entire show. We always have an anticipation of what is in store for us every Tuesday. So thank you, ma'am, for getting Oral Pathology on a global platform. Let me begin with the slide seminar. By explaining why I chose this particular name for the slide seminar, that is Histopathologic Potpourri. As we all know, potpourri is basically a mixture of dried flowers, herbs and spices, leaves, fixatives, and essential oils, which are all mixed together in a jar and kept in a jar in order to get the fragrance. I have made an analogy that oral pathology is also a potpourri composed of various lesions like cysts and tumors, fibrous lesions, mucocutaneous lesions, developmental anomalies, and infections, which all together provide an insight into the subject. So without much further ado, I'm trying to present a mixture of lesions, medley of cases, which we come across on a day-to-day basis. Let's go to the first case. This was a case of a 18-year-old female patient who complained of a gradually progressive swelling on the right side of the face since 6 months. The intraoral examination revealed buccal vestibular obliteration in relation to maxillary first and the second premolar, and you could see that the teeth associated were free of any sort of a caries, or the periodontal condition was good. The oral hygiene also was relatively okay. Unfortunately, I do not have the radiograph for this particular case, but the requisition form said that it was a well-defined radiolucency with the foci of radiopacity, and there was root resorption observed with regards to the 1,4 and 1,5. A provisional diagnosis of odontogenic cyst was given, and the surgeons went ahead and did a FNAC. The FNAC gave a yield of about 2 ml of blood tinged stocular fluid, and this is what we saw on the slides. We saw clusters of round to ovoid cells with a centrally placed nucleus, or sometimes it was eccentrically placed nucleus with abundant eosinophilic cytoplasm. Some areas it was appearing to be hyperchromatic, and they were resembling odontogenic epithelial cells, and there was a fibrinous background which could be seen. So based on these findings, we signed it off as an epithelial lesion of odontogenic origin, considering the clinical presentation as a cyst. The surgeons went ahead and enucleated the cyst and sent the specimen to us. So on gross examination, we could see a well-defined cystic capsule with a lot of proliferations within the cyst capsule. These proliferations were gritty to cut, and they were almost sandy in consistency. On a digital pressure, they were very powdery and were crumbling away. So we prepared the slides for this, and this is what we saw. We saw a well-defined capsule, and then we had this legional tissue which was composed of sheets of cells, dark blue sheets of cells interspersed with some eosinophilic material which was seen to undergo calcification. This is the hypo view of the cells. The cells were round to ovoid with an ill-defined cell membrane with sparse cytoplasm which was merging with the adjacent cells. The nuclei was vesicular to hyperchromatic. The vesicular nuclei did show some 1 or 2 nucleoli also within them. Areas of mitotic activity was also evidence. This is another view of the cells. You can see them. There was mild pleomorphism which was seen, and also we could see the mitotic activity. What was striking though was the presence of this eosinophilic material which was seen throughout the slide, interspersed between the round to ovoid cells, and you could see some cellular inclusions within them, and also they were lined by these round to ovoid cells. And this eosinophilic material was seen to undergo calcification. A sort of a globular calcification was seen in multiple areas. So we tried to identify the nature of the eosinophilic material with the help of numerous special stains. So we did a Mallory's keratin, and it was negative. That means that the eosinophilic material was not keratin. We did a Congo red for amyloid, and it was negative. We did a Van Giesen, and it gave a bright red staining, and suggestive that it could be collagen, which was the content of the eosinophilic material, which was confirmed using a Massen's trichome, which was positive for collagen again. We also did a von Cosa for the areas of calcification, which came positive. So probably it could be osteoid, which is undergoing calcification to form bone. Further, the Van Giesen was seen under polarized microscopy, and we got this yellowish to orange red birefringence, which was arranged in the form of lamellar or crosshatch pattern, again suggestive of mature collagen fibers. So based on these findings, we concluded that the eosinophilic material could either be osteoid or dentinoid. So why we thought it was osteoid? Because it was positive for Van Giesen as well as it was positive for von Cosa, and it was seen to undergo mineralization. The possibility of dentinoid was considered because it was in the odontogenic apparatus. The lesion was in the odontogenic apparatus, and the possibility of these cells being odontogenic epithelial cells was considered. And because these cells were in close proximity to the eosinophilic material and also showed a globular calcification, a possibility of dentinoid was considered. But then this did not solve our problem. We had problems like because there was osteoid, we thought a possibility of a mesenchymal origin needs to be ruled out. Though the overall appearance was epithelial, a possibility of mesenchymal origin needed to be ruled out, and also because the overall presentation was that of a odontogenic cyst and it was appearing very benign, but there was areas where you could see some amount of capsular infiltration. We also saw some atypia and mitotic figures, so a possibility of malignancy also needed to be considered. So we considered these differential diagnoses, osteoblastoma and osteosarcoma, because of the osteoid that was present and the round tooth cells, especially the small cell variant of osteosarcoma. And because it presented as a cyst and we could aspirate some fluid, we thought of, but it was a solid lesion on histopathology. So we thought, because on multiple sections we didn't get any cystic lining there. So odontogenic tumor that can present as a cyst, that is AOT, was considered. And because there was atypia and it was in the odontogenic apparatus, we thought of odontogenic carcinoma, not otherwise specified. So we went ahead and took the help of immunohistochemistry. It was cytokeratin positive, so that ruled out osteosarcoma and osteoblastoma. We also ruled out AOT because it was not positive for amyloid, nor did we get any areas of hyaline droplets or presence of the pseudoglandular spaces, pseudoductular elements. And also so the only option, and apart from it being epithelial origin, we also thought that because there was mitotic figures and cytological atypia, a possibility of malignancy was also considered. So the only option that was left to us, because it was not matching any other typical malignant ameloblastoma or ameloblastic carcinoma, we thought that we would call it as a odontogenic carcinoma, not otherwise specified. But then we went through the review of literature. There was most of the odontogenic carcinomas or the primary intraosseous carcinomas that were reported were all squamous cell carcinomas. There were hardly any which had presented as round tooth with induction to form dentinoid or osteoid. So we were still in doubt. So we thought we will seek an opinion. We sent the slides to the Armed Force Institute of Pathology, Washington, to none other than Dr. Gary Ellis. Hopeful that he would see the slide and return back to us, and you could imagine the delight that he returned the opinion to us, that he also concurred with our opinion that it could be consistent with the odontogenic carcinoma. So the final diagnosis based on these findings, and it was concluded as a primary intraosseous carcinoma with osteoid and dentinoid formation. So primary intraosseous carcinomas are rare carcinomas within the jaws. It was first described by Lewis in 1913, and subsequently the term PIOC was given by Pinbug et al. In 1971. This diagnosis can be given on the condition that there should not be any connection with the oral mucosa. The origin should be from the odontogenic epithelial residues, and we have to rule out metastasis from any other site. The 1971 WHO classification of odontogenic carcinoma considers malignant ameloblastoma, primary intraosseous carcinomas, and other carcinomas arising from odontogenic epithelium. But the most accepted classification is the 1982 classification by Elze et al., where they classify PIOCs as arising from odontogenic cyst or from ameloblastoma, or arising de novo, which can again be further classified as non-keratinizing and keratinizing. We believe that this case could be categorized as a primary intraosseous carcinoma arising de novo, the non-keratinizing variant. The current WHO classification classifies it as primary intraosseous carcinoma, not otherwise specified, whereas the rest of them have well-defined histopathological features. There were some variations which were seen with the typical features that have been mentioned with regards to primary intraosseous carcinoma. This occurred in a younger age group and a female, whereas the most cases have been reported in males more than 50 years, and in the posterior mandible, whereas this occurred in the maxilla. They are usually locally aggressive, and they present with regional metastasis, which was not seen in our current case. It presented like a cyst, and there was no evidence of any metastasis, and the patient is being followed up and she is quite okay. The radiographically, there are well-defined borders to extensive destruction which has been reported, and here we had a cystic radiolucency with foci of radiopacity. As I mentioned, most of the cases usually have squamous cell carcinoma as their histopathology, but here we found there were round to ovoid cells with induction, which added to the diagnostic dilemma. So we published this case in Journal of Oral Pathology and Medicine, and I would like to thank my mentors, Dr. G.S. Kumar, Dr. Rekha, and Dr. Vandana, who helped me to do this presentation as well as publication. When we published this, it was the 36th case in literature. It was the first in the posterior maxilla, and it was the second case with osteoid or dentinoid formation. So what does this case teach us is, when in doubt, seek a second opinion. So it actually helps in if you get an opinion which is similar to yours, it actually enhances your confidence that you have come to a correct conclusion. And if you do not agree with it also, you get a different perspective to it. So if you have a doubt, seek a second opinion. Let's go to the second case. This is a case of a 21-year-old male patient who came with the swelling on the right cheek region since 2 months, and he said it was rapidly growing. So this is the swelling. You can see it is about 4 into 5 centimeter, extending from the infraorbital area till the angle of the mouth, and anteroposteriorly from the ala of the nose to the pre-auricular area. You could see that there was elevation of the right nostril, and there was complete obliteration of the nasolabial fold. And the swelling was non-tender and it was hard in consistency. The intraoral examination revealed a nodular swelling, rather 2 nodules which were seen on the buccal aspect, which was obliterating the buccal vestibule. There was a palatal extension also, which was noted extending up till the first molar, up to the mid-palatal raphe. And you could, when we palpated the lesion, it was fluctuant, and it was soft in consistency in some areas, whereas in the rest of the areas it was hard in consistency, suggestive that there was cortical perforation and it had proliferated into the soft tissue. It was extending, if you saw the integrity of the teeth, we could see displacement of the maxillary central incisor, and it was grade 2 mobile, the central as well as lateral incisor, whereas the rest of the teeth involved, like the premolars and the canines, were grade 1 mobile. The OPG revealed a ill-defined radiolucency, which was extending from the central incisor till the molar. The superior extension could not be seen, but looks like it had extended into the maxillary sinus. The radiolucency was seen extending in between the roots, and you could see that the alveolar bone was completely destroyed in these areas, and these teeth were literally floating in the radiolucency, and some subtle root resorption was also noted. A CBCT was asked for, and here we could see the extent of destruction. It was a ill-defined lytic radiolucency, which was seen extending from the central incisor till the molar up to the mid-palatal raphe. There was complete destruction which could be seen. If you see it from the buccal aspect, the alveolar bone was completely eaten up here, extending into the maxillary sinus again, and then causing erosion of the orbital floor, extending into the nasal septum, nasal cavity, deviation of the nasal septum. The radiologist still but chose to give a provisional diagnosis of ameloblastoma or a OKC. So we referred it to the surgeon, and they thought that they would do a FNAC first, and they attempted a FNAC. They got blood tinge fluid, multiple attempts, again gave a lot of blood which was coming out of the lesion. A possibility of vascular channel, vascular lesion was considered because the amount of blood that was being aspirated. They did a CT scan, but again it showed that it was not a vascular lesion. Again, it was a ill-defined lytic lesion, and again in CT also they gave a diagnosis of a ameloblastoma. Most of the this aspirate was sent to us. Most of the slides showed a lot of hemorrhage, but in only 1 or 2 slides we could see these round to ovoid cells which were arranged in the form of sheets and clusters, and they had a hyperchromatic nuclei. They were all a monotonous proliferation with a rim of cytoplasm. Some areas it was eccentrically placed nuclei. Some binucleated cells were also seen, which was suggestive of a round cell tumor. Considering that there was a lot of bleeding on FNAC, the surgeons did an incisional biopsy under general anesthesia and sent the specimen to us. So we got multiple pieces of the tissue which were processed, both hard as well as soft, which were processed and which showed that there were sheets of cells which were invading in between the bone. There were some varying amount of vascularity seen. Areas of hemorrhage also were evident. This is a high power view of the, again you can see the sheets of cells, some areas of cystic degeneration which were noted, probably a response to the FNAC that was done there. And this is the hyperview of the cells. The cells looked slightly larger than the lymphocytes. They were monotonous, uniform, without much of atypia. You had round to ovoid cells with vesicular nuclei. Few of them had hyperchromatic nuclei, and you had some nucleoli were also seen in most of the cells. The cytoplasm was very minimal, just a rim of eosinophilic cytoplasm. Some of them had vacuolated clear cytoplasm, which was seen. This is another view. Some septae of fibrous tissue were also seen intermingled in between these. So you can see a mixture of vesicular as well as hyperchromatic cells, predominantly vesicular, round to ovoid with minimal atypia. This is another area where in the soft tissue, you can see again dense sheets of cells which are invading into the muscle. Here you could see some amount of eosinophilic rim of cytoplasm. Some of the cells were showing nuclei displaced to the periphery, giving a plasmacytoid-like appearance. So based on this, and another area, another aspect which we could see in the tumor was these areas of luminization, and within which you could see the tumors were proliferating, giving a alveolar-like pattern. This is a hyperview. This was the alveolar pattern which was evident in certain areas. Based on all these findings, we came to a conclusion that it's a round cell tumor, and we had certain points in certain diagnosis in mind. The first was Ewing sarcoma or a PNET, considering it was in a young age and it was in the maxilla. Neuroblastoma is another tumor which has been reported intraosseously. Lymphomas need to be ruled out if there is any round cell tumor, and then we thought of small cell osteosarcoma. So let's see what is Ewing sarcoma or the PNET tumor family. These are rare tumors in the head and neck tumor, head and neck region. They are thought to be Neuro-Ectodermal in origin. They are more commonly seen in children and young adults, and they have a definite male predilection. They usually show rapid growth with a duration of less than 6 months, and histologically they have, sheets of round to ovoid cells which are monotonous. There is minimal atypia, there is not much of mitosis, and you have a very thin rim of cytoplasm which can be seen. They are usually arranged in the form of sheets or lobules, which were almost consistent to what we saw in our case. They are usually positive for PAS. They are also positive for various other neural markers like NSC, S100, and vimentin positivity has also been reported. But the clincher for the diagnosis is the CD99 or the MYC2 positivity and the presence of a cytogenetic alteration, that is chromosomal translocation T1122. The second differential diagnosis was the neuroblastoma. Again, here you have round to ovoid cells, but you have brisk mitosis, and one of the characteristic feature is presence of hemorrhoid rosettes. The cells are PAS negative, and very rarely they are PAS positive, but they are usually negative. And the vimentin and CD99 is also negative in these cases, but they are positive for most of the other neural markers. Then you have alveolar rhabdomyosarcoma, which has because there was alveolar pattern which was evident in some areas, and you had these round to ovoid cells, which can be seen in rhabdomyosarcoma, but we also see a lot of atypical cells and giant cells, and typically we see this rhabdomyoblasts with cross striations, and these cells are also positive for PAS, but they're negative to CD99, and they take positivity with myogenin and MyoD1. Lymphomas, round to ovoid cells, we need to rule out lymphomas because usually they are a dense population of round to ovoid cells, and they show varying degree of atypia. They are usually hyperchromatic, and but they show different types of cells like the Reed-Sternberg cells, lacuna cells. You don't have a monotonous population. You have a varying cell population that can be seen in lymphomas. They're usually negative for PAS and positive for CD45. And the last differential diagnosis that was considered was small cell osteosarcoma, which is usually seen in young adults. And they're usually present with round cells with atypia, and there is osteoid formation, which was not seen in our case, so that was ruled out. So we went ahead and did some special stains in immunohistochemistry to come to the final diagnosis and to rule out some of the differential diagnoses that we considered. So we did a PAS, and we could see that the cells were PAS positive. They had this characteristic pinpoint positivity which was seen in the cytoplasm. So the possibility of Ewing sarcoma or the PNET still remained, and the rhabdomyosarcoma, because both of them are PAS positive, whereas the rest of the two, that is the lymphoma and neuroblastomas are very rarely PAS positive. Then we also wanted to confirm the origin of the tumor, just to rule out whether it is epithelial or mesenchymal. We did a CK and it was negative, so definitely it was mesenchymal in origin, it was not epithelial. So we had diffuse vimentin positivity. This again suggestive of the mesenchymal origin. This again ruled out neuroblastoma because they are rarely vimentin positive, whereas the rest of them are usually vimentin positive. And lastly, we did a CD45, it was negative, so that ruled out lymphoma. So we have ruled out small cell osteosarcoma because of absence of osteoid. We have ruled out neuroblastoma because it is vimentin positive and it was positive for PAS. We ruled out rhabdomyosarcoma because we have not ruled out rhabdomyosarcoma and we have not ruled out Ewing sarcoma. So we went ahead and did a CD99 and it turned out to be diffusely positive for CD99. Usually rhabdomyosarcomas are not positive for CD99. So we finally narrowed it down to Ewing sarcoma, and the final diagnosis that we gave was PNET or Ewing's sarcoma. So this is the workup that we did for this particular case. The message that I want to give for this particular case is extensive workup and interaction with clinician surgeons, and not only clinician surgeons, even our general pathology colleagues, because they were the ones who helped us with the immunohistochemistry, can actually go a long way in arriving at a good proper diagnosis and efficient patient management. Many a times it happens that the clinician sends us a report where you have just the patient name. Very rarely, we have also seen cases where the tissue is just put in the bottle and sent, the patient name may not be there many a times. So if the surgeons are assuming that we have some sort of ESP or extrasensory perception, I would like to reiterate the fact that pathologists do not have extrasensory perception. We do need to interact with we do need the details, then only we can come at a proper diagnosis. So this communication gap that is there between the pathologist and surgeon is a problem that is older than the hills, and it needs to be addressed. And I feel that you need to interact with them to arrive at a diagnosis. The next case, we'll go to the third case. This is a 45-year-old female patient with a swelling on the upper right back region since 6 months. There was history of extraction in the same area 1 year back. This is another view. You can see the expansion is predominantly in the palatal aspect. There is not much of buccal vestibular obliteration here. The O-line mucosa was intact. The O-line mucosa was normal. On palpation, it was soft in consistency, and there was a associated root stump which could be seen here. So we went ahead to see the OPG. The OPG revealed it to be a well-defined radiolucency, which with a sclerotic rim. And because it was associated with a healing socket, or there was a history of extraction there, the possibility of residual cyst was considered. And because it was also associated with the root stump of a grossly decayed tooth, a possibility of radicular cyst with 1/6 was also considered. The surgeon enucleated the mass and sent it to us, and this is what we saw. It was a well encapsulated specimen which was about 2 into 2 centimeter in diameter. It appeared to be yellowish in color. It was soft and fluctuant in consistency, and the provisional diagnosis was cyst, remember. So we cut it, and this is what we saw. It was not a cyst, it was a solid lesion, and it had yellowish appearance, and this was more consistent with the lipoma. So we went ahead and made the slides, and as we assumed in the grossing, it was a lipoma where we saw sheets of round to ovoid cells and a well encapsulated mass. This is another view of sheets of round to ovoid cells with adipose tissue, with the fibrous tissue intervening between the adipocytes. But there was something special in this case. It was not a very typical lipoma. We could see that there was areas where there was a lot of fibrous tissue proliferation, and within the fibrous tissue, we saw a lot of these blood vessels which were proliferating. There were a lot of blood vessels, branching blood vessels, capillaries, especially prominent near the capsule. And this is another area where you have myxoid degeneration, and you can see the varying sized capillaries that are seen here. This is another view which is showing thickening of the capillaries and presence of these thrombi within them. And again, you can see the varying sized capillaries present throughout the fibrous tissue in between the adipose tissue. We did a Van Giesen, which highlighted the fibrous tissue and the blood vessels. We did another special stain called as the Gallico stain, which highlighted the blood vessels which were present throughout the stroma of the lipoma. This is another view which shows the fibrin thrombi which were there within the tumor. So based on these findings, we gave a diagnosis of a intraosseous angiolipoma of the maxilla. So oral lipomas are benign tumors of adipose tissue, and they're extremely rare in the oral and the oral pharyngeal areas. That is, they account to about 0.5 to 5%, and they're usually referred to as alloepulis. They are slowly enlarging, smooth surface mask the submucosa, and they float in the formalin. This is the typical histopathology of a lipoma, where you have adipocytes which are separated by either in sheets or they may be arranged in the form of lobules. But in the present case, what we saw, what we gave a diagnosis was an angiolipoma. So angiolipomas are lipomas which have mature fat cells, but along with them you have a branching network of small vessels, capillaries, and vascular channels which can be seen. So we called it as angiolipoma. So only this was not rare in this particular case. What we saw was it was occurring in an intraosseous location, and it was diagnosed as a cyst. So we went on to see what is the intraosseous lipoma. Intraosseous lipomas are considered to be one of the rarest of the benign bone neoplasms. They account to less than 0.1% of the bone tumors in the long bones, and in the jaws they are further rare. So what could be the pathogenesis? Why do you get a lipoma in the bone? So it should not be so uncommon, because we have fatty marrow throughout the bone in most of the areas. So the pathogenesis is unclear. There are some factors which have been considered. The first one, it could be a true benign tumor of the medullary bone. Second thing, it could be a reaction to trauma following extraction. Third thing, they have thought it could be because of infarction and nutritional problems, especially through if you get a lipoma in the mandible, because it is supplied by a single artery. Or it could be a possible variant of the osteoporotic bone marrow defect. For this case, we thought it could be a reaction to trauma because the patient did give a history of extraction. We went through the profile of intraosseous lipoma. There are about 30 cases according to a recent review reported in literature. There was a wide age range reported from 15 to 65 years. There was no sex predilection. And the site was mandible was the commonest site with 26 cases, and about 4 cases were reported in the maxilla. The clinical presentation, they are usually asymptomatic. Very rarely they may present with swelling, pain, or hypoesthesia if the nerve is involved. The radiographic appearance was typical as that is seen in our case, that is well-defined radiolucency with sclerotic rim. And histopathologically, most of them were classical lipomas. There were about 5 angiolipomas reported, but they were all in the mandible. There were 3 fibrolipomas and 1 spindle cell lipoma. So the current case could be considered to be the 5th case of intraosseous lipoma in the maxilla and the first case of intraosseous angiolipoma in the maxilla. So what do we learn from this case? I have borrowed from a quote and made my own message. So there is more to cystic radiolucency than meets the eye. Be open to include some rare lesions in the differential diagnosis. So this is the rarest of rare that you can get. But you can consider, you need to be open to the idea that there can be some rare lesions which may present as cyst. And going on to the last case, this was a 26-year-old male patient who came with swelling on the right side of the cheek since 3 months. It was about 6 into 8 centimeters according to the surgeon, but it's not very discernible here because, probably it could be because of the angulation. The patient said that it was progressively growing. It was involving the masseter muscle, and progressively the patient was finding it difficult to open his mouth, and finally when he came, he could barely open the mouth. This is the picture that you can see here. A CT scan was done which revealed a lesion involving the soft tissues over the ramus of the mandible, and it was causing erosion of the mandible. The surgeon probably thought that it could be something which is proliferating out of the ramus of the mandible, come into the soft tissue. A possibility of aggressive neoplasm or a sarcoma was considered, and they went ahead with resection along with supraomohyoid neck dissection, and part of the parotid tail was also received by us. So this is the specimen that we got. You can see the masseter is completely encircled or engulfed within it, and also you have the medial pterygoid also involved here. It was a large specimen of about 6 into 8 centimeter, completely attached to the ramus of the mandible. The cut section revealed it to be a grayish white solid lesion, grayish white to a tan lesion, and the focal area showed areas of hemorrhage and some amount of cystic degeneration. Otherwise, it was completely solid. We took multiple bits from this soft tissue, then kept for decal. The mandible was kept for decal, and after a few days, we removed it out and we cut out the tissue which was attached to the ramus. And again, this was again appearing solid. It was whitish, fibrous in appearance. And then once we removed the soft tissue, we could see this area of erosion which was seen of the ramus. However, there was no intraosseous proliferation, or there was no proliferation into the mandible per se, which we couldn't identify even after taking multiple sections. So this was the picture, and we were imagining it could be some sarcoma. We would have a lot of cells, which we'll be seeing in the slide, but this is what we got. We only saw bland connective tissue, which was involving the muscle, eroding into the muscle, replacing the muscle, extending in between the blood vessels, extending in between the nerve tissue. This is a hypo view of the, you can see there's a dense fibrous connective tissue. There were some proliferating spindle cells resembling fibroblasts with the elongated spindly cells, and also they had elongated cytoplasmic processes. It was replacing the muscle in most areas. Along with that, we also saw this inflammation which was arranged in the form of aggregates. In some areas, there was sheets of inflammatory cells which were evident. And what sort of inflammatory cells did we see was predominantly plasma cells. Okay, so you could see a lot of plasma cells everywhere. You can identify them with the typical cartwheel pattern intermingled with these fibroblasts here. And then another area showed these red dots intermingled with the plasma cells with the binucleated cells. So we had a lot of eosinophils. You can see the hyalinization here, and again you can see the active fibroblasts which are having a vesicular nuclei. And a few of the areas, the plasma cells along with that had foamy macrophages or histiocytes which were also evident. Here you can see the regenerating muscle cells which were appearing to be multinucleated, and there were the muscles was undergoing degeneration in most areas. So if you see the cells, I already mentioned, they appear to be active. They were spindle. They had elongated cytoplasmic processes. Here you can see it is almost stellate, an abundant amount of cytoplasm that you can see within that. See the connective tissue, dense, fibrous, almost hyalinized. The cells are not arranged in any particular pattern. There is no streaming pattern, and you don't have any excessive cellularity that can be seen. It is all very bland. In some areas, you could see a lot of cytoplasm appearing to be stellate. In another area, you could also see these elongated cytoplasm intermingled with the eosinophils and the plasma cells. The decalcified sections showed exuberant inflammatory reaction you could see here, and also there was a lot of reactive bone which was forming. There was a sort of a periostal reaction happening, preventing the soft tissue mass to get into the bone. And when you see it in hypo, these inflammatory cells were predominantly plasma cells. You had a lot of these foamy macrophages and histiocytes. A few lymphocytes were also evident, but predominantly there were a lot of sheets of plasma cells which were seen. And these cells, you had MOD cells, you had these cells which are some of them being binucleated, so most of them thinking that they could be atypical, but the point was they were all mixed. It was a mixed inflammation. There was a lot of the macrophages as well as lymphocytes which were intermingled, but the predominant cells were plasma cells. The bone, if you see, it was a well-formed reactive bone which was formed. It was a viable bone, nice osteoblasts surrounding it, viable osteocytes within it. There was remodeling happening. You could see some osteoclasts also. A hypo view here to show you the bone very much alive, not dead or necrotic. You have a lot of these osteocytes within the lacunae. So this was the picture that we had. We had a bland connective tissue. We had some spindly cells with elongated cytoplasmic process, lot of inflammation. That's all that we had. We did some special stains just to confirm that it is fibrous tissue. We knew it, but we just wanted to confirm it, and we could see the dense fibrous morphology, which was evidence with the reddish color that we saw with the Van Giesen stain, and you could see this fibrous tissue invading into the muscle tissue and replacing the muscle tissue. So the problems that we encountered here were all this time we had whether it was benign, malignant, epithelial or connective tissue. Here we were sure it was a connective tissue. We don't know whether it was neoplasm or whether it was an inflammatory lesion. So we didn't know the nature, whether it was malignancy. The surgeon definitely thought it was a malignancy. That's why he went ahead with a resection. He thought it could be a soft tissue sarcoma, considering his or the young age. There was a lot of inflammatory cells which were seen, so the possibility of inflammatory lesion could be considered, but that presenting as a mass was something which we couldn't, put a finger on which inflammatory lesion would actually present like that. And then possibility of a reactive lesion like a fibromatosis or a nodular fasciitis could be considered, considering the young age of the patient, but there was no cellularity. It was a bland connective tissue. Still, we had them in our differential diagnosis: nodular fasciitis, fibromatosis, and of course, we also thought of an inflammatory pseudotumor. But we thought we will seek a second opinion, especially from general pathology colleagues, because it is a soft tissue tumor. And we got two diverse opinions. One pathologist said that it could be an inflammatory reaction of the bone, probably osteomyelitis. The other one said it could be an extramedullary plasmacytoma. But osteomyelitis definitely was ruled out because I emphasized on the viable bone that we had. There was no necrotic bone anywhere. I agree there was a lot of inflammation, but the bone was definitely not necrotic. So that went out of the picture. Then we had extramedullary plasmacytoma. So we took the help of immunohistochemistry to solve this dilemma for us. First of all, we did a Ki-67 just to rule out whether it is any sort of a malignancy that we are dealing with, and it showed focal positivity. That means it was not a malignant lesion. Second thing they told, because there were sheets of plasma cells, a possibility of plasmacytoma needed to be ruled out. So we did the kappa and lambda chain staining, and we found that they were positive for both. So there was no monoclonal grammopathy happening there. There was no light chain restriction. So it was a polyclonal population of plasma cells that were seen. So it was not plasmacytoma. Because it was arising from the muscle tissue, we thought of a muscle tumor could also be ruled out. That's what was suggested to us. So we did a Desmin. But the Desmin also, the cells were negative, and we could only see the degenerating muscle fibers which were highlighted in Desmin. And lastly, we thought of inflammatory pseudotumor. So we did alpha SMA. And this is what we got. Intensely positive for alpha SMA, suggesting that the lesional cells were myofibroblasts. So they were myofibroblasts which were proliferating, which I showed you that they had elongated cytoplasmic processes and active vesicular nuclei. You can see here, you can actually see the myofilaments which have been, outlined by the alpha SMA here. So dense positivity for alpha SMA, confirming that it was a proliferation of myofibroblasts. So you can see our plasma cells here. So based on these findings, that is presence of proliferating myofibroblasts and fibroblasts and inflammatory infiltrate, we signed it off as an inflammatory pseudotumor involving the masseter muscle. So pseudotumor is a generic term for a benign space-occupying lesion and IPT is a locally destructive proliferation of fibroblasts and myofibroblasts with a characteristic inflammatory appearance. And most of the times the inflammatory reaction is composed of plasma cells. So many a times they are also referred to as plasma cell granulomas. And because they are contain a proliferation of myofibroblasts, the other name which has been used interchangeably is inflammatory myofibroblastic tumors. So if you see the profile of IPT in the head and neck region, there are about 30 to 35 cases which have been reported. They are usually seen in they are wide age range from 19 months to 87 years. There's equal sex distribution. Usually presence is a soft tissue mass, and the sites that have been reported include maxillary sinus, parotid, buccal mucosa, gingiva, tongue, parapharyngeal face, and the space and the submandibular space. Usually there is no history of trauma or infection, and it is considered to be idiopathic. But what makes it sinister is it mimics a malignant tumor. It shows rapid growth. It is locally invasive and persistent, which was seen in our case. The treatment is surgical excision. High-dose steroids have been tried in some cases, and the local recurrence is usually not reported. The histopathology is very usually consists of fibroblasts and myofibroblasts, which are proliferating in the form of a streaming pattern without any atypia, lot of inflammatory cells, most commonly the plasma cells, but you can have the wide range of inflammatory cells that can be seen, and the alpha SMA positive. We didn't have this streaming pattern. There was a lot of fibrosclerotic changes which were seen in our case, which added to the diagnostic dilemma. Though we had a lot of bland connective tissue, but definitely there were cells, but they were not proliferating in the form of a typical IPT that you have. And so our case was a rare site involving the masseter muscle, and it showed extensive fibrosis and hyalinization and sparse cellularity. So what does this case teach us? So some lesions are deceptive and they present as diagnostic challenge. So I would say that this was a lesion which was a sheep in a wolf's clothing. It presented like a malignancy. It was actually a inflammatory lesion. So some lesions can be deceptive and they need to be worked up in order to come to a proper diagnosis. So that ends my slide seminar. I have tried to put forward an interesting and challenging mixture of lesions with emphasis on comprehensive histopathologic examination on routine HND that cannot be replaced. You need to correlate with clinical and radiologic findings. You need to do a workup with regards to use of special stains and IHC as and when required, and try to identify the typical as well as deviations to arrive at the final diagnosis. So the aim of this seminar was basically to create an interest in oral pathology that lingers on just as the fragrance of a potpourri. I thank my mentors in SDM College of Dental Science and Hospital, Dharwad, especially Dr. Rekha, for being my constant support. My team at KLE Institute of Dental Sciences for all their support, and finally the patients, clinicians, surgeons and technicians who form the backbone of our profession. Thank you so much for your patient hearing.
Thank you so much. That was a nice presentation, very lovely presentation. And
Thank
yeah,
I would say that it was a single take, so I am sorry if there were some inadvertent errors we creeped in into the presentation. But yeah, it did sound
that's fine.
nice.
That's absolutely fine. Sorry.
So, I'll take the question by
So,
Dr. Nazir. If
yes, I will show that now on the screen. Yes.
Yeah, definitely. I think for neuroblastoma, we most of this review that we went through showed that it was vimentin. It's not positive for vimentin. Apart from that, we also got past positivity. Definitely, we could have done a synaptophysin and a chromogranin, and that could also have differentiated it from other neuroendocrine carcinomas like a Merkel cell carcinoma. But we felt that because it was CD99 positivity, we clinched with the diagnosis of a PNET or a Ewing sarcoma. And the last case for ALK staining, yeah, definitely. I think we could have done a ALK staining for that, but it was not available. We will be doing that, sir. Because I have seen that there are about 60% of inflammatory pseudotumors do usually give a positivity for ALK staining. And why it's important now to do ALK staining is nowadays we have a drug which is available, which is being tried in especially abdominal, IPTs. Yes.
Yes. Thank you. So, any more questions? Everyone can please put them in the chat. We are here for a few more minutes. In the meanwhile, besides the good morning to everybody who we missed saying good morning to in the beginning, I think the ones who came in a little late, Dr. Rachel, Dr. Sunita, Dr. Pushpanjali, Dr. Nandini, Dr. Priyanka, Dr. Manusmriti, Dr. Divya, Dr. Iman, Dr. Vinita, who I think is your ex-student,
Yes.
and Dr. Sharda, yes, and everyone, and Dr. Sanjay, and yes, uh, yeah, Dr. Nasa has one more suggestion for you.
Yes.
Fish.
Yeah, for the ALK gene, definitely. We'll get it done, sir.
Yes, yes. So while we're waiting for a few more questions, let me share something else with you all. Right. So, as you know, we have been running Oral Pathology 360 for the last 2 years. I have been running it. And now it will be very helpful if we get some help from all of you. if you find the content interesting, if you find that we bring some value to your week of learning and to the time that you have with us, then you can just use there is a super thanks and a super chat with a dollar sign below every video, whether it's a live stream or whether it is a recorded one. You can make a contribution there. It doesn't really have to be much, as much as the cost of a cup of coffee if every week everyone pays, and we will be able to not only do our work but also definitely expand further and do much more. If it is possible for you, we'll appreciate it. And well, if not, anyways, please enjoy. And if you like the content, please remember to hit the like. And if you like today's lecture, also please hit the like. So let's see. And also always keep your comments. That is very nice if you do. Then we have, yes, Dr. Desai also saying fantastic presentation. Right. So we are waiting for more questions. Any questions? Yeah, there's a question that's come there. It will take a second to come here. Dr. Divya. Thank you so much, Dr. Divya, for that. Yes. And in the, this is actually this. Yeah, right. So, Dr. Spurti, ma'am, how do we differentiate between the aggressive fibromatosis and IPT?
Yeah, Dr. Spurti, I'll answer that for you. We did have fibromatosis in our differential diagnosis, and aggressive fibromatosis are known to occur in engage, and they usually present with sarcomatoid proliferation, but usually they are desmin positive. Okay, in this particular case, the desmin was negative, and other thing that you see in fibromatosis is usually they do not grow to a very huge size. They usually less than 5 centimeter in diameter, and you have beta catenin positivity, which is also one of the you can do that particular immunohistochemical markers. That's one thing, and one more thing that I have realized, that's also a myofibroblast. Most of the soft tissue tumors, probably you may have to take the help of immunohistochemistry in some way or the other to actually come to the diagnosis, because you have a lot of overlapping features which are definitely there. Okay, so you could go for a desmin and a beta catenin staining, which will help you to differentiate. But most of the features, usually you have a lot of cellularity which can be seen there. You have linear fascicles of cells which can be seen, and they usually do not grow to a larger size. And the inflammatory infiltrate is not very typical. As you see in IPT, you have a dense inflammatory infiltrate. Here you have a less amount of inflammation which is there. That is how you can differentiate. I hope I answered your question.
Thank you, Dr. Spurti, for that question, and thank you for answering it. So we got another contribution immediately from Dr. Divya. This is the second time, in fact, she's contributing. Thank you so much, Dr. Divya. Thank you, and thank you for being here every week. Now, on that note, we also will have another thing that we have to discuss. So please stay on till the end so we can have there's a matter that relates to the channel and to the video. So I would like your input on that. We will do that at the end. We have, I think, okay, we have Dr. Nagasudhir who says, thank you for your sharing your input and informative lecture. Thank you for attending. And yes, and Dr. Spurti also saying it was a wonderful session.
Thank you.
So, do we not have any more questions? Right, okay. So let's give everyone a few minutes, and I would like to share something with everyone in the meanwhile. So I had informed everyone that right. Are you all seeing my tab? No, now you will see it, I guess. Yes, right. So now you can go to our website, oralpathology360.com, and at any time find the upcoming events. And if you click on the events, all the week's events, in fact, even ahead of that will be there. Now, this will be populated regularly. Right now itself, you can see there is today's, there is the 16th, there is the 27th, which, by the way, is our anniversary event. And anytime you can subscribe to the calendar. So this will mean that every time we upload something, an event, it will directly come into your calendar. And you can also click on any event to find further details. So this is about the anniversary event. You will also find that the time, we have made it so that you can see the time in your own zone. So one is of course India where we are, and the other one is your time. So you will be able to see your own timing of the events. Upcoming anniversary celebrations, although our anniversary is on the 28th, but well, 27th was more convenient. So we are doing one on the 27th. It's a free event. We have two oral cancer related lectures. One is by Professor Henry Adiola. Now, he is going to be talking about omics and system biology tools for precision oral cancer diagnostics. This is something he's been working on for many years. He is very well known in the field, and he is applying all those in resource limited background, because the origin of this is from Africa. So it will help almost anyone who has no access to all the latest and the most cutting edge, but to be able to use whatever is available the best. The other person who is going to be speaking is Dr. Amir Afruge. He is going to talk about HPV positive cancers of head and neck. That is his specialty, and he talks about this. He is also the current editor of the Head and Neck Pathology. So for this, there is going to be, the event is going to be on Zoom, but as you know, Zoom has limited number of entries. If you RSVP here, then I will send the Zoom link to those who RSVP first. And also there will be, of course, a live stream simultaneously, but I am not sure that everyone in the live stream will be able to be given the certificate. So it is up to you to decide what you want to do. And if you just RSVP, we know and we will keep you informed. So this is about what is happening on the website and to keep you informed. And now coming back, let's see, do we have anything else here? No, we just have thank yous for the presentation. So I guess I will just add this now. Yes. Thank you so much, Dr. Punya, for this wonderful presentation. It was very nice. Thank you.
Thank you so much, ma'am. Thank you for the opportunity.
You're most welcome.
And we are looking
And
forward to the events in the subsequent
thank you.
weeks.
Thank you. Right. Now, the question, the big question, and I would like everyone to tell me. Now, we have, if you have noticed in the last few weeks, we have had some recorded sessions. So, what happens if I want to have people from around the world? Because obviously, not everyone is in our time zone. So, if we want to have people from around the world who can present lectures for us, then the fact is I have to record that and then play it here or premiere it here at 11 o'clock on Tuesdays. So this is what happens if we want the timing of 11 o'clock IST to remain fixed. The Tuesdays will always be fixed, but how, I would say, how fixed or how invested are you in the 11 o'clock time? And how practical it will be for those who are our regulars to attend a live stream at any other time. So, right. So the other choice is that we always stay with a live stream, but then when our speaker is from another part of the world, the timing of the live stream on Tuesday will change, which means each week it will be different depending on where our speaker is located. Now, it'll never be in the middle of the night in India because frankly, I cannot work past 8 o'clock now. So it is not going to be late night, and it's probably never going to be past 9 o'clock and never going to be before 6 o'clock our time or 7 o'clock our time. No, actually, to be more frank, not before 9 o'clock our time. So, but for the rest of the world and for everyone else, it will be varying during the day. So, I'm going to be putting up a poll on the website, and I will share the link everywhere that we are normally there, including on the YouTube channel. And I would really request every one of you to take the moment. There are going to be probably just 3 questions in there. Respond so that we can decide what to do next. Do you want that we always have a live stream, but the timings change? Or would you rather that the timing is always fixed and some are live stream and some are recording? This will be the major question, and I've been trying to decide this for some time, but it seems like it is something that basically not just me, but all of you, especially the ones who regularly attend the live stream, need to help me decide. So, which is why this has come to you. Now, beyond that, right. So these two slides that I showed you in the beginning. One is very clearly an ameloblastoma, and you will find it. It's the ameloblastoma image, which you will find on Wikipedia, in fact. Fantastic image. And uh, it's free to use. All you have to do is actually just say who is given, where it is from. The other one is an interesting one. Looks very much like a CEOT, doesn't it? Well, it's not a
Yes,
CEOT,
it does.
but it is a CEOT area in an AOT. And even more interestingly, AOT was also not the only pathology. There was a concurrent focal cemento-ossifying dysplasia in the same lesion. Now, this was a case that actually was not my case. It was from Dr. Rezwani in Iran, and then she got it to me. We went through it. There was so much of doubt as this was before such lesions and such combinations became
Yes.
accepted, and which is why we even got finally Professor Reichert, who went through it, and even he agreed. So, anyway, the link for this, if you want to see the rest of the details of the lesion, the link for that is in the description of the video. So,
I
the
also
catch
do.
is always,
Yes.
sorry, yeah,
No, no,
tell me,
sorry.
yeah.
I also had included one concurrent occurring region, but I just removed it at the last time. Maybe some other time I
Right.
can share it with you.
Yes, absolutely. The thing, was that I knew exactly where to find. I was trying to get this combination, and then, of course, I knew exactly where to find that one case. So, yes, this is the thing. This is why we keep on watching. What is very interesting is when you on social media, very commonly you see one excellent picture of a lesion, and it's the typical lesion, and you will find all the pathologists putting marvelous, excellent. And I always think not pathologists must be wondering, if it is typical, why is it so great?
True.
But I think pathologists understand. In actuality, getting a typical field is very difficult.
Very rare,
Very
rather.
rare, yes, very rare. We manage to, diagnose lesions more because our mind has got used to filling the gap.
Yes.
You know, there are variations, and our mind merges it and makes it into the right picture. So, anyway, thank you so much, everybody, for being with us. And thank you again, Dr. Punya.
Thank you,
And
ma'am.
thank you, all the viewers, for being here. Have fun, and we shall see you next week.
Thank you so
Bye bye.
much. Bye.
Welcome. Bye.